Hello, this is Dr. Brown. I am on my way to work this morning. So today I'm going to talk about something I'll call process-based formulation. And this is basically a way to do a formulation that takes into account systemic factors that might be perpetuating some pathological state. So that's very abstract. Let me first contrast it with the usual way to do diagnosis, let's say. So, in medicine, broadly speaking, if you're a physician and someone comes to you with a clinical problem, say they have chest pain, for example, that's their clinical problem, then you need to figure out what is causing that problem, what is causing that symptom or sign or lab abnormality or whatever it is. And so, once you have identified the cause, then hopefully we have a an off-the-shelf treatment for that, right? Which could be a medication or procedure, whatever it may be. So someone comes to you with chest pain, and immediately, as a physician, we're taught you come up with a differential diagnosis. And the differential diagnosis is basically just a set of plausible hypotheses for what could be causing the clinical problem, in this case, chest pain. Now, chest pain could be caused by, if I tell you nothing else, chest pain could be caused by a lot of different things, right? In the worst case, it could be, a heart attack. It could be like in the less worst case, acid reflux, heartburn. Um, it could be costochondritis. It could be, maybe it's not actually chest pain, but something more uh, in the abdomen, like an ulcer, peptic ulcer, or maybe it's gastritis, right? There's a lot of things that could cause pain in the chest region. So immediately when someone comes to you with that symptom, you are generating that plausible set of hypotheses. And usually as a physician, we do want to consider both the most common explanations for any given clinical problem and the most life-threatening conditions, even if they are not common. So again, that would be something like a heart attack, myocardial infarction. So then you would try to narrow down that list, because just chest pain, it's quite a wide list, quite a long list. So then you would ask, when did it start? Can you point to where you feel it the most? Right? You would ask a bunch of questions, trying to rule rule out some of those potential diagnoses, or at least try to narrow down the list as much as possible. If someone says that their chest hurts only right after they eat spicy food, that doesn't rule out myocardial infarction, heart attack, but it does make it a lot less likely. If you know that the person is a 20-year-old who was previously in good health and has no medical history, that doesn't rule out that they're having a heart attack, but it makes it a lot less likely, right? So anyways, that's the differential diagnosis procedure. It's generating a plausible set of hypotheses for what could be causing a clinical problem. And then you are collecting data, whether that's by asking questions of the patient or doing physical exam maneuvers or running laboratory tests. All of that data helps you narrow down that list. And hopefully you end up with the one cause, the most you've decided that it is in fact just acid reflux. So that works fine the vast majority of the time. But there are other clinical problems where it isn't just a simple one cause. It's actually a sequence of causes that end up perpetuating a pathological state by a kind of feedback loop. So let me give you a really simple example. It's almost too simple to be useful, but I think it's a starting point. And that is the case of caffeine, insomnia, and chronic fatigue. And so this is something that's close to home. It happens to me a lot. So usually I can get by just fine. If I'm not drinking too much caffeine, I'll sleep fine. I wake up fine. I'm functioning well. I don't feel tired all the time. But every so often, something will happen. Work piles up. Like there's some personal crisis to deal with, and I've got to stay up late. And so I stay up late to try to finish all the work I've accumulated. And then um, And then the next day I feel tired. And so I'm like, well, you know, I'm so tired. How am I going to function? I've got to drink some caffeine. I got to have a few cups of coffee or tea or whatever to kind of get me through the day. Okay, that's fine. It does help me feel better. So I function better that day. I feel better that day. But then that night, I can't sleep because I had a bunch of caffeine. As I've gotten older, I've become much more sensitive to caffeine. And I used to be in my early 20s, I could drink coffee right before bed and it wouldn't be a big deal. But these days, that's not the case. And so I won't be able to sleep. And then what happens if I don't sleep? Then, of course, I'm not saying I won't sleep at all. I'll probably get, a couple of hours at least. But nonetheless, I won't sleep enough. And then I'm tired the next day. Right. So what do? I'm like, oh, I'm so tired. How am I going to function? I've got, still all my regular duties to do. So I drink a bunch of caffeine again. And then I'm in a cycle, right? I'm in this cycle of I have become dependent on caffeine to sort of barely be functional. But at the same time, that continually worsens my ability to fall asleep at night. And therefore, that perpetuates the chronic fatigue, which perpetuates me wanting to drink caffeine, right? So, what is the one cause of this situation? Well, it's hard to say. I mean, the perhaps the original cause was that one night I had to stay up late and that made me tired. But that was, potentially weeks ago, right? I can't intervene at that point anymore. That's already happened. So this is, if you're trying to think about this in a differential diagnosis framework, it's a little bit hard to make it fit because this is more of a system at play, right? There are contributing factors that are all interacting with each other. And you can draw a diagram, right? You could draw a little circle that's like a node. It says caffeine, and caffeine points to insomnia, and insomnia points to fatigue, and fatigue points to caffeine, right? In a circle. And so this is a very simple kind of network, a causal network, if you will, that forms a loop and it perpetuates this pathological state of chronic fatigue. And to break up this pathological network, the easiest thing to do would be to just cold turkey stop drinking caffeine, right? And then things would get worse for a little while because then I wouldn't be able to sort of compensate for the fatigue, but then I would be able to fall asleep again. And then, eventually I wouldn't feel so tired, right? So I'd have to get a little worse before it gets better. There are more complicated causal networks where you might have to intervene at more than one point, at more than one node to get out of the pathological state. And I think basically, especially in psychiatry, there are these causal networks at play for a lot of pathological states. And that might be a reason why we see a lot of treatment resistance, so called, because we're perhaps only intervening at one node in a causal network. And that is perhaps necessary, but not sufficient to rescue from the pathological loop that we're in. Okay. So this idea, this is not mine per se. This is really something I've kind of taken from Stephen Hayes, who I guess you could call the inventor of acceptance and commitment therapy, pretty popular psychotherapy. And he, along with his collaborators, wrote a book called Process-Based Therapy. And it's basically all about this. In the book, you'll see these kind of, I don't think they call them causal networks or whatever, but that's what I'm calling them. I forget what they call them. But they're networks. They're diagrams of different causes influencing each other. And basically the inference is that, there's multiple factors at play that are sustaining some pathological state. And where can we intervene on this causal network? Okay. Now they're mostly tackling this from a psychotherapy lens. So a lot of their nodes in the network are, cognitions, that is to say, like thoughts. There might be behaviors too in there. And, they do follow the sort of biopsychosocial framework, if you will, where you're considering those three broad categories of potential contributors. So that's basically where I got that from. And I think it's really useful. And I'll offer a case of a time where I think that was particularly useful. So I had a patient who we were treating for depression. We had tried a number of different treatments for depression. They definitely qualified for the label of treatment-resistant depression. They were, they tried all the stuff that is FDA approved for treatment-resistant depression, and all the stuff that has good evidence behind it, even if it's off label. And they had some response. They got maybe 20 or 30% better, which was a lot, that's very significant for them, but certainly they weren't in remission. Their functioning was still quite low, all things considered, compared to the baseline. And so I kind of drew out this causal network as to what I thought was perpetuating this depressive state. And one of the nodes that I identified as being part of a loop that was feeding back on itself was basically feeling unproductive. And so this individual, they felt unproductive, and that kind of fed into feelings of, low worth, low self-esteem, depression. And then that made them feel less motivated to get anything done, which kind of perpetuated this. In the causal diagram, the causal network that I drew was a little bit more complicated than that. But, that was the sort of essence of this feedback loop that I had identified. So we had been intervening more on the cognitive flexibility standpoint, so their sort of ruminations had been eased by some of the treatments. The suicidal thoughts had been eased by the treatments. But this loop of lack of productivity feeding into the depression was still there. Now, there's potentially several ways you could try to intervene on that loop. One would be behavioral activation, where you really try to just get them to do something. But this person was really not functioning well, and that wasn't working. We tried it. So in this case, we tried a medical treatment. We tried a stimulant that is traditionally used for ADHD. And again, I'm not going to talk about specific names here too much in the case of a specific case, just because I need to kind of obfuscate this as much as possible to not run afoul of HIPAA and things like that. But we used a stimulant, and within about a week or two, this patient was in full remission from the depression and remained so for, as long as I was taking care of them. And that was the only change that we made. So now stimulants are not considered antidepressants in the most general sense, right? These might be used in cases of depression. Maybe I'll have an episode just on stimulants for depression, but certainly not indicate, these are not FDA approved for depression. And just anecdotally speaking, most of the people that get put on stimulants, in my experience, for indicated conditions like ADHD or say binge eating disorder in the case of Vyvanse, it doesn't really help their depression if they had comorbid depression. So these aren't reliable antidepressants, anecdotally speaking, either. However, I think this is a case where it did work because there is an identifiable causal loop where the stimulant could actually play a role in. So in this case, the stimulant just helped him be more productive and, gave him more motivation, more energy to be productive. He already had the sort of will to be productive in a sense. So it wasn't so much just frank anhedonia or, just not wanting to do anything that can come along with depression. That was the part of the depression that we had gotten better with the other treatments. But it was, this just not being motivated or having enough energy to get anything done. And I should say the sleep was optimized and all that stuff, everything else we had tried to do. And so there was a real circuit here that we could intervene on. And I think that's probably why stimulants aren't useful as antidepressants in general, because for most people, that may be not really the cause of their depression. Certainly I see lots of cases of very active people with depression that are suffering a lot. They may have a lot of suicidal thoughts, and yet they're somehow grinding through a very difficult job. They might be pretty high functioning individuals, but they're in a lot of psychic pain. So that's probably a case where a stimulant may not be very useful because it's just not intervening at a point in there's no causal diagram where the stimulant is intervening in a place that makes sense there. So yeah, that was just an example of how I think these causal networks, which I call a process-based formulation, as opposed to the more generic biopsychosocial formulation approach in psychiatry. So I think that could be helpful in cases where, and I'm not saying you do this with every person because it is a lot more work than the differential diagnosis procedure. But if you've kind of ruled out the more common single cause etiologies of depression, then I think taking a causal network standpoint, doing a process-based formulation can be really helpful. So I'll leave it there. I just parked at work here, so got to get on with it.